Assalamu alaikum, everyone. It's Dr. Sadaf here. I welcome you all for this session. Um, Dr. Usman Bashir is our today's speaker. He is very well known to all of us, but for our we have many new fellows and many new people in our group today. So let me introduce him to all of you. Dr. Usman Bashir is a consultant in anesthesia and pain management. He is the clinical lead, head of pain department, King Faisal Specialist Hospital and Research Center, Medina Munawwara. He has completed his anesthesia and pain training in UK. Along with completing his pain fellowship, he has worked as anesthesia and pain management consultant in UK for 5 years. He has also worked with us in Pakistan for 5 years, and now he is the leading pain department. Now he's leading the pain department in King Faisal Specialist Hospital in Saudi Arabia. Thank you very much, sir, for joining. Uh, in his last talk, he talked about the lumbar spinal stenosis, and today he'll be continuing his next session. Over to you, Dr. Usman.
Thank you very much, Sadaf, for inviting me again. And I'm excited to meet you all after a gap of Ramadan. Last time we met over the same topic, but we realized that there is a lot more to the topic to be covered in one session. So that's why I'm glad that we are here to cover in much more detail about this important area, part 2 of the same topic, lumbar spinal stenosis, an overview. So we are going to dig a bit more into prognosis and treatment part. So the way we are going to cover the session is, sorry, my slides are stuck here. Okay. Yeah, so in first couple of slides, I'll just recap what we did last time very briefly. Then we're going to talk about prognosis, treatment options. So this is the overview of today's session. And for each area, we just want to appraise the up-to-date evidence, what it exists, and how to learn lessons from those evidence for our clinical practice. And in the end, because the evidence is so conflicting, so confusing, we'll summarize in the end that what are the recommendations from the evidence. So a quick recap into what we already have learned, that spinal stenosis is an anatomical condition. It's anatomical narrowing of either a central canal, lateral recess, or the neural foramen. Most of the time, it is due to degenerative arthritis. However, other causes also exist, which we discussed last time when we discussed the etiology in detail. And to summarize today's talk, treatment approaches are not straightforward, and they require a careful consideration between risk benefits of each option and informed decision-making with the patient. This is a quick diagram to show the same thing which we talked about, that the etiology could be multifactorial. This narrowing of the canal could be due to the disc herniation, or could be due to the bony spurs, or could be due to facet hypertrophy. However, 90% of the time, the etiology is spondylosis, that is degenerative arthritis, which over time narrows the canals due to the degenerative arthritis. So again, recap slide, that lumbar spinal stenosis exhibits itself by neurogenic claudication, and we have to differentiate from vascular claudications, and there's a very set of clinical features which we discussed in the last presentation. Pathophysiology is mostly, it is ischemic or mechanical disruption of the nerve root function. It's not the inflammation in the spinal stenosis case. And occasionally there is a fixed nerve root injury when there is a persistent compression, for example, in cauda equina syndrome or cornus medullaris syndrome. Diagnosis is confirmed by imaging, coupled with the clinical history, which is very suggestive. In some patients, you do need to still carry out some more investigations purely to rule out other differentials, which we discussed last time. So now we'll dig into the actual topic itself. So what I want you to all understand, that in the end, we are all clinicians. So I want you all to imagine that you're sitting in the clinic and you've got this patient now who you have diagnosed with lumbar spinal stenosis, and he's sitting in your clinic, and you will be faced with various questions with this patient will ask you. So we'll take today's talk in terms of those questions that a patient is asking to you in the clinic. And you are answering those questions in an informed, evidence-based way. And that way we'll dig into the evidence which exists for various treatment modalities. So patient will naturally ask that, doctor, what will happen to me with this condition if I leave it untreated? How do you treat this condition, doctor? Can I do anything if I don't go for injections or drugs? Should I go for surgery or not? If I don't do anything, when should I call the doctor? So these are all the practical questions which you are faced with in the clinic. And we will dig into the answers to each of them with the help of most up-to-date evidence, and then critically appraise those evidence and come at the conclusions. First question patient is asking you, doctor, what if I don't do anything about it? So naturally, he's asking you about the prognosis, the natural history. As we discussed previously, that about 80% of the causes are due to degenerative spondylosis. And due to the nature of the disease, it is relatively benign. And the consequences mostly are in the domain of pain, discomfort, limitation in the activities of daily living, progressive disability, and as a result, overall decreased quality of life and other psychological and behavioral consequences. The only exception are the red flags and the serious pathology, which we have already spoken to in the last presentation. I'll just relate to some of the studies which are quite old, but they talk about the prognosis. There was this old study just done only on 32 patients. They followed those 32 patients who were proven to have spinal solidification, and they followed them for 4 years. Nothing was done for these patients, not surgical, neither non-surgical treatments. And 70% of those cases with confirmed diagnosis remain unchanged in terms of symptoms. 15% show improvement and 15% worsen. There's another interesting study in about almost 270 patients. It was again a low quality evidence, but they looked at the patient's symptoms and what patients actually want to improve. They did a treadmill test on about 270 patients and then studied a survey from those 270 patients. Out of those, almost 80% patients preferred walking with less pain compared to increase in the distance of walking. So reduced pain was much of a preference by most patients. So in summary, in terms of prognosis, it is mostly benign. Neurological disability is quite rare, fortunately. And as you've seen, most patients remain stable over several years of follow-up. However, there are exceptions, and there are some patients in which the symptoms will become quite disabling and restrictive, where you want to take action. So now you've told this patient, the overall prognosis, he will still inquisitive and asking you, what are my treatment options, doctor? So the treatment options again depend upon these 3 areas we'll cover. First thing is triage, because we want to rule out serious pathology or progressive neurological deficit. And then once we have ruled out those areas, then we look into non-surgical and surgical treatments. So before I dig into the treatment options, I just want you to pay attention to this slide for a minute or so, because we are going to be talking about these evidence. So these are the international grades of grading the evidence and recommendations. Level 1 recommendations are strong recommendations, and evidence grade, if it is A, it is high quality evidence. Whereas if it is C, it is low quality evidence. So for example, if the recommendation is grade 2C, then it's a fairly weak recommendation based on the level of evidence. Therefore, whichever option is opted out of the various options may be equally reasonable. So keep that in mind when we talk about further treatment options. Whereas grade 1B, on the other hand, is a very strong recommendation. And if you deviate from that, there must be a very strong reason for deviating from grade 1B recommendation. So having known about this, we'll dig into the treatment options. As I said, that first we'll triage the exception that this patient does not have any progressive neurological deficit, is not falling into any red flag categories which demand urgent surgical decompression. If he's not falling into that, then all other patients are falling into a general trial of conservative, non-surgical treatment which should precede the surgical treatment. However, this is also a grade 2C recommendation, which is a fairly weak recommendation based on the overall evidence. So it means that any of the non-surgical treatments could be equally good or not, as we will see further. Whereas the exceptional case is a grade 1B recommendation, which is a very strong recommendation. So in summary, the non-surgical treatments used for lumbar spinal stenosis include these, which we all know. They're physical therapy, lifestyle modification, rehab, pharmacological options, and epidural steroid injections. So we'll just dig into a few of them and the evidence for them. First, I'll go into the overall evidence review, which exists for all of these non-surgical therapies. And what is interesting to find, the evidence quality is moderate to high, but for all the non-operative treatments. And there's a systematic review, which is not very old, it's about 2012. And you can see that there are 21 trials in about almost 2,000 patients. And they were able to find that the evidence for non-operative treatment is overall lacking in terms of recommending any specific recommendations of one over the other. Sorry, my slide is a bit stuck. Okay. So another study, a review article, which was done for non-operative treatments of spinal stenosis, again, was unable to find any high-quality evidence for non-operative treatment. Therefore, there were no specific recommendations made that go for this treatment or the other. In BMJ in 2016, a review article was published which concluded from all the systematic reviews and Cochrane reviews that there is insufficient evidence to recommend any specific type of non-surgical treatment. So this was the overview of all the non-surgical treatments. So with that evidence in mind, now we'll go forward into various non-surgical treatments. So first of all, it's physical therapy, which is the mainstay of conservative treatment. That do physiotherapy, it will get better on its own. So what does the evidence say about physical therapy? Evidence base is quite lacking because the physiotherapy regimes are not standardized. So that's why making specific recommendations is quite difficult. Most of the recommendations are about stretching, strengthening, and aerobic fitness, with the main goal of being muscular stabilization and correction of posture. Some of the techniques focus on reducing the lumbar lordosis and increasing the lumbar flexion, because that, if you remember from last lecture, that improves the overall stenotic pathology. However, if you use braces for a long time for that on the other hand can weaken the abdominal muscles. So it's fairly controversial area. Few studies found in terms of physical therapy, which are not very high quality. One of them is this one, where they compared two types of physical therapies, and they found that manual therapy and treadmill is better than the lumbar flexion exercises and ultrasound and treadmill walking. Physiotherapy does have an indirect role for reducing the weight, because when you reduce the weight, if you remember from the last lecture, the overall pathophysiology involves axial loading over a period of time, which causes degeneration. So when you reduce the weight, you reduce that axial strain on the spine. So in that way, it is helpful. On the same notes, if you remember from the last lecture, the pathophysiology, as lumbar spinal stenosis patient prefers to cycle because he has a stoop forward posture, which reduces the overall stenotic pathology in the spine. And same holds true for the aquatic exercises. And both of these indirectly reduce the weight as well. So they have been shown to be of benefit. Only one convincing evidence as far as physiotherapy is concerned exists in the post-operative area, where patients have had lumbar surgery. And the meta-analysis showed that those patients who had extensive rehab immediately post-op had better functional status in 6 and 12 months post-operatively. So that was all about physiotherapy. Overall, there is no major harm. So we'll conclude at the end of the summary when we talk about the summary options. What about pharmacotherapy? I'll not go very deep into that because we have a lot to talk about in epidural steroid and surgical options. So I'll just very briefly cover that. As an overview, there are no studies which show clear superiority of one class of drugs over others. The most classes of drugs are like NSAID, acetaminophen, adjuvants like gabapentin, pregabalin. Some concerns, the choice actually matters upon individual patient characteristics and the complication profile according to the patient. For example, in older grade groups, the associated cardiovascular risk with the certain types of NSAIDs. We found in context of lumbar spinal stenosis and pharmacology, I found one evidence-based study, which was a randomized controlled trial for pregabalin. And interestingly, it showed that pregabalin is no more effective than placebo in terms of controlling the neurogenic claudication due to lumbar spinal stenosis. So this study is particularly in reference to lumbar spinal stenosis. It's not in relation to neuropathic pain. We now move on to a much deeper and confusing area of epidural corticosteroid injections. So as we all know and familiar, there are various routes by which you can inject the epidural steroid injection through translaminar route, through transforaminal approach, and through the transhiatal approach through caudally. And neurosurgeons are also advocating some new routes of transfacet approach. However, I did not find any evidence currently supporting that approach. It looks very bold to me. So these approaches we are familiar with, but let's see what is the evidence. The evidence goes quite far back in the history, dating from 1980s. So I'll start from the past and keep moving forward to the current age to the better quality of evidence. The main thing which we need to know, which is a concluding statement in most of the trials and the recommendations from larger bodies, that the overall evidence is limited because the quality of studies and approach include quite a heterogenic patient population, which include both radicular as well as lumbar spinal stenosis patients. So definitive conclusions are based on the limited evidence. So keep that thing in mind. So I go back, as I said, back into history. First papers were in 1985 when they started appraising a prospective randomized trial, which did not find any long-term benefit of the epidural steroid. And they looked at both acute disc and spinal stenosis patients. But this is quite an old study and only 73 patients. It's a prospective randomized double-blind fashion. So it's not a very strong evidence. The next study we look into is going back to 1995. It is a slightly better evidence, a systematic review of randomized trials. However, the trials which they used in the study had flaws in design, and the studies were inconsistent. Overall, they concluded that efficacy of steroid injection has not been established. And if at all, the benefit was short-lived rather than long-lived. We now move on to some other studies which were positive as well. The main positive study was in terms of caudal epidural blocks in elderly patients. They looked at patients with mean age of 76 with MRI confirmed diagnosis of lumbar stenosis and followed them for up to 10 months. The study was only in 30 patients, again, very low quality evidence. But the conclusion was good that there was significant pain relief of reasonable therapeutic benefit for elderly patients. And this could be important among the patients who have poor response to drug or who are not suitable for surgical therapies or who do not opt for surgical therapies. Next one, again, slightly, we are moving further down in the timeline, 1998 now. So this study looked at about 53 patients. And the reason I'm quoting this study, because this study divided the patient into three groups. One group received only local anesthetic. The group 2 received local anesthetic with steroid. And group 3 received only saline. Sorry, so let me revise. Group 1 received saline. Group 2 received local anesthetic only. Group 3 received local anesthetic with steroid. And the interesting result was that there was no difference in the patients who received epidural with steroid compared to epidural with local anesthetic alone, which also emphasizes the hypothesis which we presented in our last presentation, that the etiology here is not inflammation, it is ischemic and mechanical. So that is why steroid or no steroid, both had same benefit they showed in this study. But again, it's only 53 patients. And the type of study, they're just testing with the 20-minute walking distance. We are now moving on further in the future, 2013. That is a big study. That is a spine patient outcome research trial, the famous sports trial. So they did a subgroup analysis within that group of patients who had lumbar spinal stenosis. So, and they divided the patients into those who received epidural steroid within the first 3 months and those who did not receive epidural steroid injection. So interestingly, they found that the patients who were within this sport study group, who were in the non-operative treatment and who received the epidural steroid, in those, almost 58% had a crossover to the surgical treatment versus the non-epidural steroid, 32%. So that is interesting. I don't know the detailed reason for that, but that was a significant finding. And they looked at the long-term benefit. They did not look at the short-term benefit. They looked at 4-year follow-up and found that epidural steroid injections were associated with overall less improvement over a 4-year time period. And another interesting finding in this trial was that patients who received steroid injections were associated with longer duration of surgery when they came up to surgery and longer hospital stays. So our next study is, again, more robust evidence, a systemic review of meta-analysis. That is in 2015. Epidural steroid injections for radiculopathy and spinal stenosis. Again, it's a heterogeneous group because they looked at both spinal stenosis as well as radiculopathy, which could not be due to spinal stenosis. So there were 30 RCTs for radicular pain and there were 8 RCTs for lumbar spinal stenosis. So for radiculopathy, the evidence for epidural steroid was showing beneficial effect in immediate and short-term reduction in pain as well as function. So strength of evidence, SOE stands for strength of evidence. Strength of evidence is moderate. However, there were no long-term benefits for radiculopathy. By short-term, in this study, it means up to 3 to 6 months. Immediate term means 1 week to 1 month. And the long term is up to from 1 year to 4 years. So when this study looked at the lumbar spinal stenosis, which is our current topic, there were no clear effects of epidural steroids for spinal stenosis in the long term or in the short term. The strength of evidence is low to moderate though. They were not able to find any serious harms, but the study also reported that the reporting of harm was suboptimal. Therefore, the strength of evidence is low. So this is as far as we go in terms of strongest quality of evidence is this study, which is concluding that for radiculopathy, there is benefit, which is short-term and not sustained. The evidence for effectiveness in spinal stenosis is limited because of limited number of studies, but though that evidence is not showing any effectiveness. So I am sure all of you, like me, must be quite confused by now. So let me summarize the evidence for epidural steroids. The best evidence for benefits come from trials on patients with radiculopathy due to herniated discs. And they conclude that the beneficial effect is there for short term, but not long term. But limited available evidence does not support the use of epidural injections in lumbosacral spinal stenosis. So I want you to just internalize this, that limited available evidence does not support the use. So limited available evidence does not mean that there is no evidence. It's just the fact that the evidence that they have is not strong enough for them to recommend it. And the third group analysis concluding statements in most of the larger group studies is that some patients obtain more benefit than others, and it is still a reasonable offer of a trial to offer it as a trial to those patients who have not found benefit in the other conservative approaches, or those who are not suitable candidates for surgery, or those who are not interested in surgery. So the expert group's final recommendation or clinical statement is that they can be offered a trial of corticosteroid injection if they are falling into this category. What about the number of injections and interval between injections? Interestingly, there has not been any robust conclusive evidence from the current studies that how many injections per year or how much should be the interval between the injections, what should be the exact dose. However, the expert group's review summary is that one or a series of up to 3 injections. If you're doing up to a series of 3 injections, they should be at least not less than 1 month apart. So do not repeat them after 2 weeks or 3 weeks. At least give 1 month gap. The reason for that is coming further ahead. Additional series of injection is not indicated if the first injection does not improve the symptom. And the studies and the evidence recommend that in 12 months, they do not recommend more than 3 epidural injections. And the studies which strengthen this evidence, they studied about 3,000 patients and showed that each successive epidural injection increases the 5-year risk of vertebral fracture by a risk factor of 1.2 due to the increased risk on bone fragility. So when we are doing epidural in our patients, we have to give the informed decision in form of all these informations. So conclusions from these, it seems that doing up to 2 injections in a year is an acceptable way forward. So conclusion of non-surgical treatments for patients who do not have fixed or progressive neurological deficit, conservative treatment is suggested. However, as we saw in the very start, that this is a grade 2C recommendation because the overall evidence is not in the high category, grade category. For physical therapy and pain medication, their overall efficacy has not been rigorously evaluated. And the available limited evidence does not support the use of epidural injections of corticosteroids for lumbar spinal stenosis. Now, so you've gone through the lengthy discussion with this patient, and now patient is now confused, like all of us. And he's now asking, doctor, should I go for surgery? So if we have neurosurgeons here, they will be better answering this question. I will not jump into their domain. I'll just very briefly cover the role of surgery now in this topic's context. So what are the surgical treatments? The surgical treatments, when we discuss about surgical treatments, we talk about patient selection, the timing of the surgery, what surgical approaches exist, and what are the surgical complications. Patient selection is the key factor when it comes to surgical treatments. And deciding on surgical intervention in the patients who do not have progressive neurological deficit. So I keep on repeating this very important clause that we are talking about those patients who do not have progressive neurological deficit or who do not have any serious pathology or red flags. There, the patient preference should be weighed very heavily in decision making, and it should be an informed decision. And patients should be informed. The last line is very important, that the benefit of surgery decline over a period of time, and repeat operations are often required in almost 15 to 25% of patients, studies have shown. So once we know these key factors, we'll just dig into one of the studies which I found quite interesting, which was helping us in patient selection. It was a big study. They looked at the predictive factors for post-operative clinical outcomes after the spinal stenosis surgery. It was a systematic review, so good quality of evidence. And what they found that the negative predictors for the outcome, bad outcome of the surgery were these, like depression, poor lifestyle, cardiovascular comorbidities, and scoliosis. The positive predictors were male sex, no offense at females, please. Younger age group, better walking ability, better self-rated health questionnaire answers, less degrees of other comorbidities, and more pronounced canal stenosis, interestingly. Other criteria for patient selection are smoking. So if somebody is smoking, then it is associated with bad surgical outcomes because of non-union, delayed healing, increased pseudoarthritis, and it reduces the overall bone fusion by impairing the revascularization. So, and again, this is supported by a good study when they looked into almost 357 patients who underwent spinal fusion. So the non-union rate for those who stopped smoking for 6 months or longer was similar to non-smokers. So they had the same benefit if they stopped smoking for 6 months or longer. Other patient selection criteria is obesity. The obese patients will have more comorbidities and more complications. However, on the contrary, obese patients are also likely to have poorer outcome with non-surgical treatments compared to non-obese patients. So that puts us in a difficult state, that which means that they might benefit from surgical treatment more because they have poor response to non-surgical treatments. Another interesting thing I found in the evidence was this sedimentation sign, which is relatively new and the robust evidence is lacking, but the evidence which currently exists supports this. Sedimentation sign is that when a patient lies supine in the MRI, the lumbosacral nerve roots settle posteriorly with gravity. So if this sign is positive, that indicates that patient is less likely to improve with conservative treatment and more likely to have greater benefit from surgical treatments. So again, interesting finding in patient selection. Surgeons might know about it better. So next area about surgical treatment is timing of surgery. And for that, the main deciding factor is the one which we keep repeating, that patients with progressive neurological deficit or serious red flags are one category and all other patients are in the other category. So patients who have progressive neurological deficit, it's grade 1B recommendation that they require urgent surgery. Yeah, sorry. Hello? Can you hear me?
Yes, sir, we can hear you. किसी का mic गलती से
About
on
to
हो गया, तो
finish.
I think yes, sir, no problem, sir. You can carry on. किसी का mic गलती से on हो गया था, sir. Sorry
Okay.
for the interruption.
So we were talking about the timing of surgery. So there are two main categories. Just keep things simple. So two main categories. One patient is those who have cauda equina, conus medullaris syndrome, or those who are showing progressive neurological deficit. For them, there is grade 1B recommendation. The only grade 1B recommendation in this entire topic is in this category. So they require urgent surgery. All these three categories. Luckily, cauda equina or conus medullaris syndrome is very rare in the context of spondylosis. It's mostly in the setting of trauma or tumor. So that is a good thing. And as we know from previous lecture that lumbar spinal stenosis, 70 to 80% is caused by spondylosis, like degenerative arthritis. And they showed that the degree of neurological recovery is related to the speed at which the compressive lesion is corrected. The study did not conclude about the exact duration, though, that how fast they should go to the surgery. So our next category about surgical timings is all other patients. So surgical treatment of lumbar spinal stenosis, with the exception of the previous slide, is elective in all other patients. And the benefit is mostly in terms of symptom and improvement in terms of pain improvement, function improvement, rather than preventing the neurological impairment. Because if it was due to neurological impairment, we'll follow this recommendation, which is in this slide. We'll go for the surgical option. But if it is not falling that category, then you are in this category. It's an elective decision. Interesting study in the Spine Journal, which is a prospective 10-year study where they followed the patient with lumbar spinal stenosis, divided them into conservative and surgical management, and they found that delayed surgery appears to produce benefits that are similar to surgery when conservative therapy is selected as the initial treatment. So basically, they are saying there is no difference if you choose conservative treatment first. The outcomes are same compared to that group which chose a surgical treatment first before opting for conservative treatment. So when we talk about surgical approaches now that we know that which patients need surgery, patient selection we've spoken about timing of surgery. Now we'll very briefly just conclude our today's talk with approaches. Again, this is not our direct area, so I'll just be fairly brief with this area. So you have to look at two main categories, whether the spinal stenosis is with spondylolisthesis or without spondylolisthesis. By spondylolisthesis, what we mean, what we talked previously in our last lecture, that whether there is anterior or posterior sliding of one vertebrae over the other, along with instability, with or without instability. If there is a fracture in the pars ventricularis, there will be instability. So that defines the surgical approach, what approach they are going to take. And we'll just very briefly cover that. So if the spinal stenosis is without spondylolisthesis, then approaches are these: laminectomy, spacer implantation, minimally invasive decompression. I've not gone into details of laminectomy. It is one of the most common procedures performed. I'll just talk a little bit more about the other two options because evidence is relatively new in them. Intraspinal spacer implantation is overall shown to be beneficial, less invasive. It is showing benefit in those patients who have shown classical intermittent claudication symptoms of neurogenic claudications. They did a study in 191 patient where they put X-top implant of titanium alloy, which showed more than 50% of patients showed benefit lasting up to 4 years. So good results overall, but still good quality evidence in terms of systematic reviews is not out there yet. Minimally invasive decompression is gaining particular interest because of a cost of length of stay, reduction, and overall less invasiveness. The quality of evidence which has shown benefit is very relatively low quality evidence. They are only observational studies. However, slightly bigger studies, which was a group in Netherlands, which showed Norway, sorry, which looked at nearly 900 patients. And they looked at the outcomes at 1 year, and they compared laminectomy with micro decompression, like minimally invasive. And they found that the complication rates between the two groups were similar after the propensity matching. However, the only benefit which they showed in the micro decompression group was they had shorter hospital stay, 1.5 day mean difference compared to those who received laminectomy. So this study is a randomized controlled trial which looked at the long term, which again is a part of a sport trial which we spoke previously. So it's a subgroup analysis within that. They looked at 8 years outcome. And interestingly, they found that surgical benefit beyond 8 years, they did not found there was any difference compared to those who were non-surgically treated. So interesting enough. So the maximum benefit most of the studies found was up to 4 years in most of the studies. So next major category is spinal stenosis with spondylolisthesis. If it is unstable spine with spondylolisthesis, then surgeons opt for lumbar fusion. Whether it is with or without instrumentation, that is again a detailed topic. However, the studies found that if there is addition of instrumentation, the fusion does improve, but the rate of successful fusion does not imply that there is overall clinical outcome is beneficial because the overall complications are high when you do instrumentation. So benefit of adding the fusion to the decompression of is limited to no benefit in the absence of spinal instability. That is what they concluded from the evidence. Very briefly, last slide, so just bear with me. Surgical complications, yes, the ballpark rule is that the rate of complications is proportional to the degree of complexity of the surgery. For example, laminectomy without fusion has much lower complications compared to laminectomy with multiple transpedicular fixations and instrumentation. Multi-level fusion has high rate of complications. Mortality is overall 0.2 to 2.3, infection, hematoma, DVT. And you have to inform the patient that re-operation for recurrent stenosis or for adjacent disease is also not rare, as we saw in a study previously. So it's been quite a marathon of evidence. with all of you and must be quite muddled up in the mind now. So I will just conclude in my last slide based on all the things which we have discussed, that what are the summary conclusions. So in summary, prognosis of spinal stenosis is benign. And in the absence of neurological deficit, you should opt for conservative treatment first. However, it is a grade 2C recommendation. Physical therapy and pain medications, they have not been rigorously evaluated. The limited evidence does not support the use of epidural steroid injections. However, we discussed the expert group recommendation as a conclusion of the epidural steroids. Urgent surgical consultation for rare patients with rapidly progressive cauda equina or conus medullaris syndrome. Any other patients other than that fall into grade 2C recommendation that surgical consultation should be obtained. However, there should be a shared decision-making process with information about treatment options, and patient preference should also be included in that. And as we studied in the last two slides, that in the absence of unstable spondylolisthesis, decompressive laminectomy without fusion is preferred. Thank you very much. Sorry, there's been quite a lot to talk about, and that's why I chose a separate session for this talk altogether, because as you've seen that there is so much to talk about and there is so conflicting and confusing evidence. I'll leave it open for discussion and open to the house. Off to you, Dr. Sadaf and Dr. Khalid. Any questions?
Thank you very much, Dr. Usman, for a very detailed and evidence-based overview of the prognosis and treatment of lumbar spinal stenosis. Now, we'll look into the questions and comments and views from our senior faculty and our colleagues who are with us. So you can type your message in the chat box, or you can unmute your mic and please come online.
Thank you, Usman. It was a wonderful presentation covering all aspects and creating confusion as well.
Yes,
So
yes.
I think before I start my comments, I think we should wait for the questions. If anyone wants to ask
Sadaf,
questions.
you can read out any questions if they are in the chat, because I was not opening any questions in the chat window.
So just one comment. Serious complications of epidural steroid injection.
Yes, I did not cover it because of the time restraint. There have been papers and FDD recommendations as well, like stroke due to the spinal ischemia, that is and paralysis as a result, and even deaths, so they are the serious complications. And the less serious I touched upon in one of the slides was that if you repeat it frequently, hypothetically, over 5 years' time, they studied in 3,000 patients that in 5 years' time, there is 1.5 times increased risk of vertebral body fracture due to the effect on the bone fragility from repeat steroid injections. Other than that, there are routine complications with any procedure, like as you know, a transient increase in the blood glucose dynamics as well. But the serious ones are to be considered of the stroke due to the stroke and the spinal ischemia, if there is a particular steroid goes into the spinal vasculature. But overall, from the bigger systematic reviews, what they said that because they could not conclude about the serious complications because they were underreported. That's why the quality of evidence about the complications is low. There was an AP3 audit which only looked at the surgical epidurals. They did not look at the pain epidurals. So we cannot cross-relate from those that epidural.
Okay. Sir, is there any, there's one more question about the use of dexmedetomidine in patients with herniated disc. So would you like to comment on that?
There's evidence in up-to-date, which I appraised in the recent studies. There was no bigger studies or meta-analysis to comment on that. I personally do not have any anecdotal experience with that. The only other area which they commented on is TNF alpha, etanercept, I think. And the evidence for that was inconclusive in lumbar spinal stenosis. Dexmedetomidine, there was no current evidence-based studies I found. There might be ones going on, or might be ones which have not crossed my eyes in my review. But if anybody in the audience has any experience, feel free to comment.
I also never seen any article showing the benefits of dexmedetomidine in backache. But this epidural dexmedetomidine is helpful only in post-surgical pain.
Yes, that is a totally different context. Absolutely different context. That's why we cannot cross refer to this area. Because here we are talking about an area which already has overall less degree of evidence. When we talk, when they studied the overall evidence for non-surgical treatment, the overall conclusion was that evidence is lacking. So grade 2C recommendation, for all the conservative treatments. So that's why the treatment options are very confusing. It has to involve the patient's discussion and their choice, and based on risk benefits, what they opt for. And the expert group conclusion on epidural steroid was that if the patient has not benefited from other conservative approaches and they do not want to opt for surgery, then a trial of epidural is absolutely correct choice for those patients. They should be given that trial. Although the limited evidence, I again keep repeating, the studies, they are limited in evidence. The biggest trial which we had was 8 RCTs looking at the spinal stenosis, whereas 30 RCTs look at radiculopathy, for which evidence is good.
So is there any role of hypertonic saline or hyaluronic acid?
No, there was no, in the treatment options, it was not mentioned. In the current recommendations from the larger bodies, I did not find this as an option for spinal stenosis. The main ones were, they would mainly appraise the evidence for steroid injections and spacer device they talked about.
May I comment?
Yes, sir.
Yes.
Both have been used in the cases where there were epidural adherence. So they are used to break the epidural adherence which occurred because of previous surgeries or some trauma. So they have been used in the past, both this hypertonic saline and hylaraundise, to break the adherence in the epidural space.
Yes. So that is again a totally different area then, because if you remember, Sadaf, the spinal stenosis, the overall pathophysiology is chronic axial loading and degenerative spinal pathology. So in the etiologies, the epidural adhesions they have not been mentioned in the etiological studies which they have done as a cause of spinal stenosis. So maybe that's why they have not included it in the treatment options of spinal stenosis. But yes, in epidural adhesions.
And one point should be clear to all the trainees or audience that spinal stenosis is narrowing of the canal, which can be because of either because of ligamental hypertrophy of ligament of flavum, or because of disc protrusion, or because of thoracic narrowing or facet joint hypertrophy. There are three.
So just have a look at this picture. This will take a screenshot of this picture.
Yes.
This will. So it could be bony spurs, could be facet hypertrophy, could be disc herniation, could be long-term ligamentum flavum hypertrophy. So anything compressing central or lateral canal from any area can cause spinal stenosis. 80% of the time, it is a spondylosis, a degenerative disease. And 20%, it could be other pathologies like tumor, infection, and other rare pathologies. And we discussed it at length in the previous talk, so you can get it from Sadaf.
And basically, the talk revolves around these 3-4 factors. And the
Absolutely,
the
absolutely. So
alignment.
do not confuse it with the radicular nerve root pain. Okay, so this is only talking about lumbar spinal stenosis. On the all the evidence which I have gathered is only talking in context of lumbar spinal stenosis only. So it's not talking about nerve root, single nerve root, or polyradiculopathy. So for that, evidence is separate, you know. So just don't get confused between the two.
Sir, our next question is about the techniques by which we give the epidural injection. Did you come across any study in which they compared the two techniques, caudal epidural and the TFI, which is more effective in treating this
No, the
stenosis pain?
systematic reviews, which were the latest one, did not comment on the type. So this figure just shows as they just commented upon the approaches. They mainly concentrated more on the outcomes actually, but they did not define in those that which one were done by transforaminal approach and which one were done by translaminar approach. There might be separate studies looking into that, but when I was looking for robust evidence for spinal stenosis, the systemic reviews did not separate the technique and the outcomes. The most beneficial outcome, as you've seen, was shown by caudal in the elderly patient, but that was a very small study in only 53 patients. And the systematic review, which was the strongest evidence, showed good evidence in short term for radiculopathy. So I imagine for radiculopathy, I've not looked very deep into that study. I've just highlighted the summary recommendations. So if it is a radiculopathy, they will have most likely gone for transforaminal approach because the favorable results were in radiculopathy, whereas in lumbar spinal stenosis, the evidence was not supporting it. So this was the caudal epidural study, which had a favorable response, and this was the big study, you know, the systematic review, which looked at 30 RCTs for radicular pain and 8 RCTs for spinal stenosis. And they concluded in benefit for radiculopathy, whereas no clear effects with spinal stenosis.
Thank you, sir. Sir, next question is about any role of dynamic X-rays in suggesting treatment.
Yes, that goes down to our previous lecture. We spoke about that. That is upcoming. I'll just bring up my previous lecture here then, because we talked about that we covered in our last talk. So there is a role of dynamic imaging. However, it is quite latest, and the logistics and overall, let me just bring up that slide of dynamic imaging. And then I will save for sure. Yeah, dynamic change of dural sac cross-sectional area, DCSA in axial loaded MRI, significantly correlated with the severity of symptoms. So this is a 2012 study. Yes, so there is a role, yes. Dynamic X-ray, I don't know. The studies which I studied showed us about this dynamic dural sac cross-sectional area in MRI. Changes correlate with the severity of clinical symptoms in spinal canal stenosis. Whether it's a practicalities and logistics, whether you can practically do them or not in the day-to-day clinical practice with the patient load. And most of the guidelines from the larger bodies take that factor into account of the country logistics and the practical recommendations. So, but the research evidence exists that there is a role.
Next is what's the long-term benefits of epidural injection and how much of the and for how much duration will it be beneficial? I think this has been discussed in the talk.
Yes, this is quite nicely summarized in this one. That the benefit duration when they looked at there were 3 durations they looked at. The largest study, the systematic review. One is immediate term, one is short term, and one is long term. Immediate is 5 days to 2 weeks. Okay. Short term is 2 weeks to 3 months, and long term is intermediate is 3 months to 1 year, and long term is more than 1 year. So for epidurals, they could not show benefit more than short term in the larger studies. Whereas for spinal stenosis, the benefit was not shown more than the short term. So no long-term benefit for either radiculopathy or spinal stenosis. Long-term benefit is from the surgical options, yes, but that too is up to 4 years maximum. However, like exceptions occur.
Okay, sir, next question is about radiofrequency ablation. Is there any role of radiofrequency ablation in lumbar spinal stenosis?
No, I did not go. I've the various recommended guidelines from up-to-date group and bodies. This was not in the options recommended. Maybe the evidence is not strong enough yet. It may have a role in disc-related pathology itself, where it's causing a single root problem. But overall, in 2 to 3 levels, spinal stenosis, it was not one of the options in any recommendations. But it's a separate topic on its own, which needs quite detailed discussion, of various components, risks versus benefits. What do we inject? What is the long-term benefit? It is covered in other topics, but in the context of spinal stenosis, no guidelines mentioned it.
Thank you so much, sir. I think that's all from our audience. Do we have any other comment or?
I think in anecdotal practice on conclusion, because what these expert panels are recommending, yes, the limited evidence does not suggest that there is no evidence. So and they have said it in conclusion themselves, this point, that those patients who do not get relief from other conservative therapy, a trial of epidural should be offered to them, especially if they are not the candidates for surgery or if they are not interested in surgery. So a lot of our candidates fall into this category, So, so the purpose of this article was to present the up-to-date evidence, so that you are up to date with current studies and what are the conclusions and what are the grades of evidence. Surgery, when should they must go for surgery, and everything else is equally open, grade 2C, So that's why I highlighted this slide. If you just take it as a take-home message that like most of the options mentioned in our study are falling into type 1C recommendation, which if I can get this slide, yeah.
So what is
So
the
grade
dose of
2C
steroid
is a
that you are
weak
using?
recommendation where other alternatives may be equally reasonable. So if you look at all the conservative options, systematic reviews, they are falling into 2C recommendation. The only grade 1B recommendation is the urgent surgery where there is serious pathology, cauda equina, conus medullaris, or progressive neurological deficit. That is grade 1B recommendation. So house is quite open, basically.
Sir, what is the dose of steroid that you are using in your clinical practice for this at single level? Or what are the recommendations? One of our colleagues want to know.
At lumbar level, even if you use a particular steroid, there is no serious harm has been recommended. And the studies which have looked at one steroid versus the other have not had any conclusive evidence that one is more longer acting than other. So methylprednisolone, triamcinolone are the most common use. But as you can see, even in the systematic reviews, they have failed to show the benefit lasting in long term. So you can imagine that using one steroid or the other is not going to make a big difference in your outcomes. Yes, sometimes we see that, especially when I was practicing in Pakistan, that one company is better than the other. So use that company steroid, you'll get better effect from that. And sometimes there's anecdotal evidence with our own practice that we prefer from our own outcomes that, okay, triamcinolone is, I am having better outcomes with that compared to the dexamethasone. So I'll carry on using that for lumbar spine. And for cervical spine, the jury is out that you must not use any particulate steroid there. So there the choice is only non-particulate dexamethasone. Any comments from Dr. Khalid Bashir or on this, the choice of steroid? Or Atiq or anybody else?
I agree with you that in the cervical spine, they are very cautious about use of particulate steroids, especially when the transforaminal route. And it is strongly recommended that transforaminal in cervical area don't use particulate. Lumbar area it doesn't matter. But again,
And I must say, Sadaf and Khalid, that this topic is lumbar spinal stenosis, which is a chronic condition. Don't confuse it with acute radiculopathy or acute discogenic pain. That is a different approach altogether.
That is what I want to say, that this today's
Exactly.
topic
Don't get confused here. So this is
limited to spinal stenosis, not to the whole management of backache.
exactly. So that's what I've appraised here. Only lumbar spinal stenosis. Okay.
Yes. For spinal stenosis, it was a comprehensive talk. I can only say.
It was good evidence. I was very interested to find that. That's why I made it a separate talk. It was not possible to complete it there.
If I look at my experience, spinal stenosis patient, they do show very good recovery, very good pain relief, even with spinal stenosis. So again, depend upon the pain generator, because there are 7-8 areas from where the pain can arise.
Exactly.
And regarding the long-term benefits of epidural steroid, although the evidence says that there is no long-term benefit, but practically I have seen that with epidurals, even the muscles, they are tense in the spinal intervertebral space, multifidus, etc. They are in spasm, which causes, or paraspinal muscles, they are in spasm, which causes back pain. But with epidural steroid and local anesthetic, we give instant, immediate pain relief, and of course, muscle relaxation, which gives long-term benefit.
And you must keep into mind that these studies are all done in European populations, which have other confounding factors. Nobody has done an extensive review in our population, in the Asian region, in the subcontinent region, in the Gulf region, So none of these strong evidences are coming from these areas. And as you said, in your experience, even in my own clinical experience in Pakistan, I saw great benefit, compared to the benefit which I used to see in UK from the same procedure. So because we don't have data to support what we say, maybe it's a time that we do a big study in our population to show that it has benefit,
Okay. Yeah. Thank you very much. Thank you very much, Usman. I have taken a long time.
Thank you very much, everybody. Thank you. Thank you, Sada, for inviting me again. Thank you.
Thank you so much, sir, for always available. Thank you so much.
Thank you for changing the day for me. Thank you.